Hi, my name is Geoffrey Nighswonger, and I'm going to be presenting on diabetes. This is for class nurse 442, CSU San Marcos. So this patient, it's a 67-year-old male Mexican who's currently homeless and unemployed. He is divorced. He has no children, no support system currently in place. Primary form of medical insurance is Medicare. He is diabetic, and he has been for the last 13 years. Currently, on a pharmacological basis, he takes Lispro, Lantus, and metformin for his diabetic management, and non-pharmacological interventions include education, exercise, and diet. Primary nursing diagnosis is deficit of knowledge. Nursing interventions for case management include providing the patient with educational materials, visual aids, and videos, having the patient teach back information taught to him, allowing the patient to test his own blood sugar in front of the nurse, and ensuring that the patient has adequate supplies and access to medications. The goal is going to be that the patient will have blood sugars between 60 and 110. The patient will be able to demonstrate proper blood sugar monitoring. The patient will leave the hospital with enough supplies to last 1 month, and the patient will not be readmitted within 30 days. Self-care capacity, the patient is alert and oriented. He is ambulatory. Currently, he does not exercise, and his diet is limited to what's given to him in the form of charity. He goes to food banks, he goes to Long Beach Rescue Mission, different churches, and that's where he gets his food. Along with that is that he has limited access to resources, which definitely does affect his medication and medical compliance. He has reported numerous times having his blood glucose monitoring equipment stolen, as well as his medications. He's more than willing to be compliant with his treatment. However, his lack of resources and the fact that he gets so much stuff stolen from him prevents him from being compliant. Additionally, not having a home or access to running water and shelter, he does have very poor hygiene and foot care due to that, and he is a high risk for developing foot ulcers as well as neuropathy. Currently, his activities is independent. He is independent with his activities of daily living. For this patient, the priority issues for discharge planning. The big thing is that discharge planning needs to go and start when he is admitted because he has been readmitted numerous times for noncompliance, 5 times in the past 6 months. The big thing is going to be education about medication, diet, and exercise. He is going to need to know all about his medications, the dosage, proper use, potential side effects, the purpose of his medications. Additionally, he's going to need to know about any new medications that he is prescribed and if that's changed from his old prescriptions as well. Dietary restrictions as well, and the importance of following a diabetic diet, and the importance of exercise and medication compliance. Proper foot care as well, and signs of symptoms of hyper and hypoglycemia. Big thing for him is going to be follow-up appointments and making sure that he is available to go, that he has transportation, and that he knows all the dates, times, and locations of those. Once again, access to medications, equipment, and resources such as food and shelter are going to be a big thing for him. As far as location, currently he does get $675 a month from Social Security, which that can go and be used to help for accommodation. It is incredibly important for this patient to go and to obtain proper shelter. If he has proper shelter, he is going to be more compliant and not be a high risk. He's not going to be coming every single month or every 30 days like he has been. So if we get this guy shelter, then he'll have access to a place where he can store his medications and equipment and not have it stolen. He can go and have regular food. He can go and have a clean place to monitor his feet and make sure he doesn't get any ulcers. Big thing for him is going to be giving him an actual shelter. With the SSI, it does give him an advantage because Long Beach is the second largest homeless population, or has the second largest homeless population in the country. So we have the Long Beach Rescue Mission, a lot of boarding cares, group homes, transitional homes. Using that SSI will definitely help to go and to get him into a place. So the nurse case management strategy on a patient level, it's education. On a system level, it's that supporting with transition. So education, the big thing is going to be teach back. Teach back meaning that we go and that we teach the patient about a medication and he teaches that back to us. That lets us know that he actually understands it. Or we teach him how to go and check his blood sugar and then he demonstrates that for us. Teaching him about discharge instructions, nutrition, exercise, We need to also go and make sure that he's aware about the importance of appointments and he has transportation, and also frequently monitoring this patient's status post-discharge. So I want the case management to call this guy. He does have a cell phone, once a week for 1 month, and then every other month to make sure that he still has his glucometer, that he's still taking his medications to help make sure he does not come into the hospital again in 30 days. On a system level, like I said, supporting those transitions. So discharge planning beginning upon admission, and then with any of our homeless population that are high risk for readmissions, we need to go and make sure that we are following up with them post discharge, and that we are providing them with access to different resources. On a patient level, so according to Tellez, Andrews, Harbin, and Hernandez, researchers nationally and internationally recommend that approaches targeting high-risk patients include education, communication, self-management, and self-efficacy strategies. Additionally, according to Kornberger et al., currently 47% of the population, or 90 million Americans, have difficulty understanding medical information given to them by their healthcare providers. So we look at the fact that this gentleman is a high risk for readmissions, and that a majority of our population does not understand the information that's being provided to them from their doctors and their hospital visits. So the big thing is education and communication. One, we need to go and teach this guy about what's going on with him, the pathophysiology, medications, treatment, prognosis, interventions, diet, exercise, how to live with diabetes. And we need to look at communication. Everyone learns differently. Some people prefer to read. Some people want a video, audio, paper handouts. They want to go and actually touch things with their hands. We need to know, how does this guy learn best? What language is best? And we need to go and give him information in the way that he understands it, and then use that teach back to make sure he does. And once again, the case management follow-up weekly for 1 month and then every other month to help make sure that this guy is not going to be coming back within the next 30 days. He's going to need to be assessed for proper understanding of how to take his medications, how to monitor his care, and then he will need to go and demonstrate proper foot hygiene as well. On a system level, in a study that was done by Kushel, there was a study done in Toronto that looked at homeless populations in comparison with non-homeless populations with the same diagnosis and prognoses. And what they found was that those who are homeless were 3 times more likely to be readmitted. So we are dealing with, especially in Long Beach and at my hospital, high-risk population. And so we need to go and begin discharge planning upon admission. We need to be monitoring those high-risk patients post-discharge. If they do have access to a cell phone, we need to stay in contact with them to make sure that they have the resources they need to not go and come back in for diabetic ketoacidosis or hypoglycemia. We also need to go and help these guys to sign up for Social Security and health insurance. Giving them those resources will help give them shelter and access to regular care, and provide them with resources for local shelters and transitional homes and food banks. Utilization review, according to Powell and Tahine, the big thing is that it's going to go and help ensure that the care that we provide is cost effective. Basically, what utilization review is it revolves around the idea of making sure that, one, that medical treatment, it's of high quality, effective, and efficient, but the big thing is that it's appropriate for each patient, that we're not doing tests that shouldn't be done, that the patient isn't staying longer than they should. So for this patient, we need to make sure that his length of stay is appropriate. If we discharge him too early, he's going to be coming right back. If we discharge him to the wrong location, he's going to be coming right back, and ultimately it's going to cost the hospital money. We need to ensure that we have proper documentation so that we do get reimbursed, and we need to understand that these case managers are going to be using their time to call the patient and other patients post-discharge, and I can see how that can be used as a waste, or seen as a waste of time. However, if we make this phone call once a week and stay in contact with them and make sure that they have everything that they need to stay compliant for their treatment, we're going to be saving ourselves a lot of money down the road by preventing readmissions. As far as quality and safety issues, we need to monitor the trends. For this particular patient, he is a high risk. We look at his trend, and he is readmitted about every 30 days for the same thing. The trend is that he gets his stuff stolen, his medication or his equipment, or he runs out, and he has very limited resources. We need to collaboratively work together to intervene to help prevent that from happening again. Uh, Additionally, diabetics are a high risk for developing foot ulcers, according to Lavery et al. This guy's homeless. He has poor foot hygiene. He has limited resources. He's diabetic. He is a good candidate for developing neuropathy and poor circulation to his lower extremities. So he is a high risk for developing foot ulcers. So the big thing for him, for safety, is that we need to teach him how to assess his feet, how to care for them, and what to do if he does get any wounds. In order to look to see if our patient level strategies were effective, we need to go and look at, one, if the patient is able to demonstrate and teach back the information provided. Is he able to go and test his own blood sugar? Is he able to go and administer his medications properly to give the right dosage? Additionally, does he get readmitted? If 30 days have gone by and this patient has not been readmitted, our goal has been met. What we did worked. If he comes right back 3 or 4 days later, we didn't go and do the best that we could have done. We need to go back to the drawing board. On a system level, we need to go and look at our current data for readmissions for this population, for this demographic. Currently, we might have certain patients that are frequent flyers for the same thing. We need to go and look at how often those people are coming in. And then on a system level, we need to go and implement changes to try to change that. So as I mentioned earlier, those system level changes include early discharge planning, monitoring them post-discharge, Social Security and health insurance acts, helping them get that, as well as giving them resources to local resources. So we need to look at our current data of how many of homeless diabetic patients are readmitted, how frequently for diabetic ketoacidosis, hyperglycemia, implement these changes, and then every month we need to go and reassess and see, are these patients still coming in every 10 days, every 30 days? Are the readmissions, is that length of time in between each admission getting wider and wider? If so, then these changes, they are effective. If there's no change at all, then once again, we need to go back to the drawing board and make appropriate changes. These are the references that I used for this PowerPoint. Thank you very much for your time.